Okay, this is good. Okay, that's good. It's lovely space.
Yeah, so we can actually take this also.
Yeah. Very good.
So that we have our
Yeah.
when we have transmission, so we sit here and we have the whole IT team takes care of the people.
Great. That's such a good thing. It's so good to see everything. It's so great to spend the time with the team from such projects and overall program. See the hospital. So inspiring. It just really helps. We talk a lot. Hello. Shit. Hello. Shit. Really here. Hello. Yeah.
We just wait for a few minutes.
Okay. Yeah. Thank you. Okay. Good. This is okay? Yes. You happy? Good. Yeah. That's running Professor Gastroenterology. So Professor Gastroenterology. Let's do that. That's enough. That's absolutely enough.
So, good afternoon, everybody. I think today for all of us at AIG and for, of course, our IBD team has been a very special day because we had a global stalwart in IBD visit us. And this is just to tell a few words. It's indeed an honor and so much excitement as I talk that Professor Charlie Lees, a leading gastroenterologist and IBD specialist of the world, and from the University of Edinburgh, is here. And he will now deliver a talk which is very relevant to us. And I think for all the fellows here, you need to understand that we are going to see more and more of IBD. We will need to take decisions every day. How to treat, how to diagnose, and how to treat optimally. So I think today's talk is going to tell us that how to improve outcomes. Without much ado, Charlie, thank you so much, and the stage is for you.
Thank you very much. Thank you, Rupa. Thank you, everybody, for making me so welcome today. It really is a huge privilege to come to India for the first time, and for that to be here in Hyderabad, and for my first stop to be at this wonderful institute, the AIG, and not only to come visit, but to come visit you in your workplace and see you at work. And you've all been incredibly welcoming and generous with your time today, so thank you very much indeed. I'm going to talk about inflammatory bowel disease, which has been the passion of mine for the last 20 plus years, working on this area in Edinburgh, but increasingly with an eye on what is happening across the world. My goal, and that of my team, really is very simple. The mission is to improve the lives for people living with inflammatory bowel disease. And that, for me, is not just in Edinburgh, across the UK, across the Western world, but it's across the world. And, we really do now recognize this as a global problem. These are my disclosures. So IBD and the gut sits at the center of so many different disease processes, but it really is with inflammatory bowel disease that the problem is so profoundly disturbed. And it's extraordinary, actually, the level of detail we now know about what's happening across this single layer of epithelium between the bacteria and the mucosal immune system. So we're going to talk a bit about the impact of IBD and the unmet need. To set the scene, we're going to need just to go back to look at the full story before we go into treatment paradigms. And then I'm going to end by sharing a few key takeaways from our landmark PREDICT study. And then we're going to look at some really practical take-home points. So the most important thing we do today, every day, is keep the patient at the center of our journey. We do this for them, and we should remember that our patients don't just have significant physical symptoms, they also have profound psychological symptoms, from fatigue and mental exhaustion to anxiety and depression. The long-term complications of the disease, hospitalizations for flares, surgery, stoma formation, for example, the complications of the drugs and the disease, the long-term sequelae of inflammation, including cardiometabolic outcomes and neurodegenerative outcomes, and importantly, the impact on everyday life, from spending more time in the bathroom to impact on studies, work, relationships, intimacy, family planning, and food choices that may be restricted to manage or to avoid flares. So IBD is highly heterogeneous, it's truly dynamic, and it's also terribly unpredictable. And these are all significant problems. Here's a patient of mine that sticks in my mind a lot, young Jack, who comes to me after I have already spent the last decade looking after his father, who has the worst Crohn's disease I've ever looked after in my career. I already were looking after his older sister, who had terminal Crohn's disease and ended up having an operation. And already one of my colleagues was looking after his younger sister. So he comes from a multiply affected family with, on workup, panenteric Crohn's disease, this is back in 2017, but already we were practicing early effective therapy for Crohn's disease. So he goes straight on to infliximab and azathioprine. But despite the best management, he ends up having a perforation with an urgent colectomy and endoileostomy. Despite that, and going on to medicine post-operatively, he has an aggressive recurrence. And it's only now, with his fourth major line, his fourth different class of IBD medication, that I've got him into deep remission. So this illustrates so many different points, from the disconnect between symptoms and inflammation in this case, to the family history element that we see in IBD, to the aggressive nature and to the complications that we can see. But perhaps most of all, unmet need today, the best medicines with the best care we can possibly give. This unmet need is profound. Everything from raising awareness and ensuring equity of to breaking the therapeutic ceiling with better therapies, to ensuring we have better systems for monitoring our patients. These need to be frictionless and provide our patients. Who's going to get aggressive versus quiescent disease? Who's going to respond to what drug and when? Who's going to get the complications of the drugs and disease? And to think holistically for the patient in terms of wellness aspects, fatigue, pain, sleep, diet, energy, psychological function, but also holistically in terms of non-IBD issues that our IBD patients are getting, like cardiometabolic neurodegenerative disease. And most importantly, really starting to think towards how we develop a roadmap leading to the prevention and ultimately cures of these diseases. But let's just start at the beginning for a minute, and I won't take too long a detour for today's talk, but I do want just to think briefly about who gets IBD and why, because the answer increasingly is it can be anyone. We've known about it in the West for 150 years. A Scot, Thomas Dalzell, first describes Crohn's disease in 1913. We see Crohn, and then the first cases in China in the late 50s, 60s, all progressing to this global pandemic of IBD that we're now seeing. And you'll be familiar with these 4 stages of IBD, where we now have in the Western world this stage here, this third stage, compounding prevalence. Our incidence levels are stable, but the prevalence increases. And you can see that here. These are the data we published in Gut 5 years ago now for Edinburgh here, nestled in this east coast of Scotland, where in 2018 our point prevalence was 0.8%. 1 in 125 people living with inflammatory bowel disease. But look what happens when you go out to 2028, which of course we're very close to now. You get up to almost 1%. And if you look in older populations here, the prevalence is already crouching up to 1.5%, because these people are living with IBD for longer. So this is, for us, already a huge problem. This slide is subtitled, "Or why is my IBD clinic getting busier and busier every week?" But of course, it's here that you're seeing this acceleration in incidence, and indeed, in some of the emerging nations countries, they're probably still in the emergence phase, but here you truly are in the acceleration of incidence phase. And if we look at where the world's population is, the growth and the stabilization, and perhaps the decline of populations in Asia, there are massive growth of population in sub-Saharan Africa. If we see 1% of all the world's population living with IBD, we have a true problem. And a clue, of course, that IBD is an illness of modern living, with the key epidemiological signal being urbanization. It's interesting to hear how that in India you are still predominantly rural versus urban. The WHO's inflection point globally, though, was 2007. That was the point where more of the world's population was living in an urban setting versus rural. And you can see how sharply this is diverging year on year. So I like to think about it in terms of environment, microbiota, and genes. And what we have is the modern environment, our modern living environment, exerting its effect on the gut microbiota, reducing microbial diversity that you see from immigration studies, you see from case control studies, you see the impact of Western lifestyle, diet, and other factors on reducing gut microbial diversity. And then this genetic effect, which appears to be profound in IBD. Crohn's disease is highly heterogeneous. We've been looking for disease genes now since the 1990s. It's 25 years next year since the discovery of the NOD2 gene and Crohn's disease. Really pivotal findings. But we now have a large population of IBD patients from around the world where we've done genetic studies. 110,000 European cases, 1,200 South Asian patients, and 14,000 from East Asia, with well over 1 million controls. In the latest meta-analysis presented at ECHO this year by Laura Facal from the Sanger, we can now identify over 600 independent regions of the genome independently associated with IBD susceptibility. And we map this out, and we can already see really interesting patterns and lessons about disease biology, from adaptive and innate immunity to epithelial barrier and more. And more we're seeing that this is giving us clues to the molecular architecture of the disease. More and more this is giving us druggable targets to give us better therapies for the disease. It's perhaps not yet giving us the precision medicine for IBD that we want, but this is essential. Don't get us wrong, this is essential. And if you have 10,000 South Asian IBD DNAs, you can see just how big a contribution that is to this transethnic study that really enables to get the resolution at the very important level to understand what the true causative mutations and genes are. The environment is what has really captured the world's attention recently. There's way too much to talk about in just this introduction to do it justice. We are very interested in the role of diet, and I'll show you very briefly later a component of that. But we now have good evidence for ultra-processed foods, high-fat diet, low-fiber diet, emulsified sugars and red meat in IBD susceptibility. But it's not just diet that's the environment. It's industrial pollution, it's fertilizers, it's cigarette smoking, it's antibiotics, particularly earlier in life. It might be surgery like appendectomy. It's almost certainly stress as well. And this is, I think, something that is going to get more and more attention recently. Stress, this relationship between the person and the environment that is appreciated by the person as taxing or exceeding their resources and endangering their well-being. We are learning that in IBD, the relationship between the brain and the gut is bidirectional. It's not just active IBD that is making people depressed or anxious. The brain signals are working the other way. In our big predict population of 2,500 people, we asked them at entry what they thought was the main cause of their flares. This big spike in the pink is stress. The second biggest spike here is dietary changes. Interestingly, the third biggest one down here is alcohol. But you can see stress far outweighs everything. And just last month in Nature, scientists in what's been described as a black swan discovery have found that there is a circuit in the brainstem that recognizes inflammatory signals in the periphery and regulates them. We didn't know this was a thing. You have inflammation in the body, there is a neural circuit they've identified in the brainstem that is regulating the response to that. So this is something we have to look at. And of course, the microbiome, and what a pleasure it was to hear about the ambitions from your studies here today in the gut microbiome lab at AIG Hospitals. So that's just a very brief background. I could talk about this for hours and hours, and I'd be delighted to do so again. But I really want to talk about treatments and treatment strategies so we can improve care for our patients. The goal of our therapy is to heal the patient. What do we mean by that? We mean by healing the gut, of course, mucosal healing. That, as gastroenterologists, is the holy grail. Heal the mucosa and we solve everything. Well, we know that's probably half of the story. Maybe it's even less than half the story, but it's certainly an important half. Promptly diagnose IBD, optimally treat the inflammation, assess, monitor and adjust, tight control, getting us to mucosal healing. But also the top part is so important. Promptly address psychosocial issues, optimal assessment, assess, monitor, adjust, tight control of that. What does it all mean? Treat symptoms, control gut inflammation, minimize steroid exposure, ideally keep our patients out of hospital. Ideally, we really want to alter the natural history of the disease, prevent it from progressing, decrease surgeries and stomas, and critically minimize complications from the drugs as well as the disease. And we now have this amazing range of drugs. These are the drugs that I have available to me today, all the way up until the very recent launch of etrasimod and mirikizumab this year for ulcerative colitis. We've had last year risankizumab and upadacitinib for Crohn's disease. We've had 2 years ago now filgotinib and upadacitinib for ulcerative colitis. Go back a bit further, and we've had tofacitinib for ulcerative colitis. We've had ustekinumab and vedolizumab for Crohn's disease and ulcerative colitis. And going 25 years back, the anti-TNF drugs. On the bottom, importantly, we track the biosimilar and the generic versions. For us, that was critical. Because if you take all of this away and go back 23 years, the drugs that we had were ineffective. Steroids were prescribed liberally, patients had a poor quality of life, and our treatment targets were non-existent. And even when we got the new therapies, they were too expensive, we had no idea how to use them properly, and stomas, surgery, hospitalizations, and gut failure were all too common. And so it's my deep passion that what we help everyone else in the world do is not go through these 2 decades of mistakes that we did, but to skip ahead with best practice as possible from the start. So we need a treatment paradigm, a framework by which to treat. And we have one. It's treat to target. It's oft told, but it's important. Take a patient who has active Crohn's disease or ulcerative colitis, give therapy according to their risk or what's available, and in the short term, get your patient feeling well. It's what you want as a doctor, it's what they want as a patient. But beyond that, don't just get them feeling well, get them feeling completely well, normalize the biomarkers, heal the mucosa, and then strive for normal quality of life and absence of disability. If you don't hit your target, iterate and go along. Or monitor, and adjust on the results of monitoring. And we do that largely through using calprotectin testing, but you can do that through whatever means works best for you here. So we need a treatment paradigm to frame our therapy, and we need to communicate that with our teams and our patients. We then need to work out how to get the right drug to the right patient at the right time. Now, getting the right drug to the right patient is fiendishly difficult still, even in 2024. But the right time, we now know. In Crohn's disease, the time is early for the majority of patients. Early on in the disease course, in Crohn's disease, patients predominantly have inflammation. Later on, This is 10, 20, 30, 40 years. This is from our huge international genetic study that I led on with 16,000 Crohn's patients. You can see that by the end of follow-up, the vast majority have complex disease already. And so with this in mind, we know that we can do better if we treat early, or we thought we could anyway. This is showing you what we did in Edinburgh when we started patients on biologics 20 years ago. You can just look at the bottom line here, this blue line. This is patients with Crohn's disease. When I started working in IBD in Edinburgh in 2003, where patients would take a very long time to get their first dose of a biologic. You can see at 10 years, it was less than 10%. 2005 to 2008, when patients were diagnosed in that era, they were getting their biologics a bit quicker. They were then getting it a bit quicker again. But it's only in the more recent era, 2014 to 17, that you see the whole shape of the curve is changing. So for a decade now, we've been practicing this top-down therapy for Crohn's disease patients. We've been able to do that because the cost of therapy has dropped dramatically. And that was embracing biosimilar versions of anti-TNFs, already a decade in the making. And with this, we see our surgical rates fall. Look at this here. This is time to first surgery in Crohn's disease. This is that earlier cohort, 2001 to 2004. It's a 20% resection rate at 5 years. But if you go to the more recent cohort, it's more like 10%. A very significant reduction. This is population level data. And the other really interesting thing that we did was that we showed that hospitalizations are decreasing. These are hospitalizations for our entire IBD population in Edinburgh. But what we do here is we split this by hospitalizations in IBD patients for non-IBD reasons, like a fall, a stroke, a heart attack, sepsis, pregnancy. It's static. But hospitalizations for IBD-related things is falling very significantly. So things are getting better. We have, however, noticed this phenomenon that our bed days are accounted for by a very small proportion of patients. In fact, just 3% of our IBD patients account for 50% of bed days. And these are people with both very, very complex Crohn's disease, typically with nutritional failure, gut failure, often with very complex psychological needs as well. So to improve outcomes, we've embraced two things here. One is biosimilars, and the other is data. And over the last 15 years, data from a number of really key experiments, and there's just a few listed here, from Sonic that showed definitively that infliximab and azathioprine was better than infliximab, that was better than azathioprine. The risks of stopping, or the chances of stopping and flaring. The data from PANT showing the risk factors for primary non-response and immunogenicity. Dose guided studies, profile, and safety studies as well. Profile, of course, has now given us the categorical evidence that a top-down therapy is better than a step-up therapy in the UK in patients with moderately active Crohn's disease treated with infliximab and azathioprine very early. Does that mean that you here in Hyderabad need to treat all of your newly diagnosed patients with Crohn's disease with infliximab and azathioprine? No. Does it mean you should think about, in all your newly diagnosed Crohn's patients, a top-down strategy? I think it probably does, but then you need to work out what that means. It probably means an advanced therapy, probably, but if it doesn't, it means some way of risk assessment. Because the risk here is not that we overtreat these patients, and I think we are at risk of overtreating some of these patients who after diagnosis will do very well. The big risk is that we undertreat these patients, the patients that relapse and remit and flare and progress over time. And your hospital might be full of newly diagnosed patients with complex IBD now. Our hospital's full of the patients that have had Crohn's disease for 20, 30, 40, 50, 60 years and have the ravages. My clinic is full of these patients who've got gut failure as a result. Unfortunately, we don't have good biomarkers at diagnosis. We do, I think, have good ideas of following trends over time, and I'll talk about that briefly in a bit. But if you look at the profile data, unfortunately, the biomarker that this was set up to look at did not give us a clear benefit. But I think we can see clearly here, from my experience and from the profile data, that with Crohn's patients, early TNF is effective, but it's not perfect because it won't work for everyone. That's the primary non-response problem. There's a significant attrition with these drugs over time. That's the secondary loss of response problem. And thirdly, and importantly, if your main biologic is infliximab and ustekinumab, then ustekinumab works much less well after infliximab has failed. So there is a significant issue here that we only start to get around really with P19 therapies and with JAK inhibitors in Crohn's disease. So vedolizumab and ustekinumab, that next big era, we've been using vedolizumab for a decade now. I dosed the first patient for ulcerative colitis exactly 10 years ago in the UK. Ustekinumab a bit less. These therapies have not really shifted the needle for us dramatically. Vedolizumab in UC for sure, a lot of ustekinumab use in biofailing Crohn's patients. We are on the cusp, literally on the cusp. It's later this month when Stelara goes to a biosimilar version. That is going to enable us to use that drug earlier, and I think we will. This is really important data. This is the primary outcome of CView. We can say from profile that infliximab plus azathioprine is really good. We've got lots of data, including from CALM, that adalimumab's really good. And we now have CView that shows that ustekinumab's as good as adalimumab. So I think we will be using this quite a lot. And if cost was a problem, and if the biologics were all the same price, we'd probably use a lot more ustekinumab, and I think we will be. And then we've got these small molecules now. I know you don't have upadacitinib for Crohn's disease yet. We used quite a lot of tofacitinib off-label for Crohn's disease, or I did anyway, prior to upadacitinib coming along line. It does work quite well, I think, for some people. Upadacitinib in the phase 3 data, and in our experience, we've treated over 100 patients with Crohn's disease, refractory Crohn's disease with upadacitinib, and we've seen good response here as well. So we have, I think now, a very significantly improved toolkit very recently. And I'm not going to talk too much about this because I know you don't have access to it at the moment. But the P19s are also providing additional benefit. But perhaps the most important thing here is that if in the next year or so, your ustekinumab prices are dropping significantly with biosimilars, I would be using them first line quite a lot in Crohn's disease. So what do we do? What do we do in our clinic day in, day out? Well, we don't give everyone with newly diagnosed Crohn's patients a biologic. If patients have mild to moderate disease, we might just give them induction therapy and monitor. How do we monitor? We monitor calprotectin every 2 or 3 months for the first year. If it's not dropping below 250, we start a biologic. If it has dropped below 250, we just hold back and we continue to monitor. We have shown that that makes a difference to what happens next. If your calprotectin at the end of a year with Crohn's disease is more than 250, your disease progression over the next 5 to 10 years is very high. But if it does drop below 250, you do pretty well actually over time. And the best way to get your calprotectin below 250 is treat with biologics, but it's not the only way to do it. So if you have mild to moderate Crohn's disease, you might just induce and monitor the Calpro. But if you've got more moderate disease, we would start adalimumab monotherapy. If you've got moderate to severe, we would start infliximab and azathioprine. And then after TNF failure, we've been using ustekinumab, but we would now increasingly use a P19 or upadacitinib. Now, I know this is now perhaps wishful thinking here, but we are not using azathioprine or methotrexate monotherapy anymore. I think they probably do still have a role to play where financial constraints are at play. I would use them in preference to 5-ASA for sure. We don't use them in Crohn's disease. That saves money. And we have managed to persuade a lot of our patients to stop smoking. When I first started working in IBD, a third of our Crohn's patients smoked, and it's now more like 7 or 8%. A massive difference over time. So early effective therapy in Crohn's disease is so pivotal. Does the same apply in ulcerative colitis? Well, the answer is no, it doesn't. This is a beautiful study from Shomron Ben Horin, who looked at the Crohn's disease studies and showed here that early therapy was better, time since diagnosis, better outcomes on the left. But in ulcerative colitis, it's flat. You don't see that. So what does this mean? I think what it means is that you don't need a top-down therapy in ulcerative colitis. But what we've learned with ulcerative colitis is that you need to expediently or quickly manage the flaring patient. Because if you can quickly get on top of the flaring patient, you can then stop that attack from progressing to a severe treatment refractory disease that needs surgery. And having rapid access small molecules makes a profound impact here. Tofacitinib, filgotinib, and upadacitinib. We have all three. We used a lot of tofacitinib, 280 patients we started. We now use a lot of filgotinib. Why? Because it's the cheapest by far for us of the JAK inhibitors, but we still use a lot of upadacitinib too. We use the cheapest drug because we are in a cash-strapped economy. They all work. If I only had tofacitinib, I'd be pretty happy. But actually, filgotinib's a great drug, perhaps not quite as potent. But these drugs work fast. It's extraordinary. This is the UPA data. I could show you graphs for all three. With tofacitinib back in 2018, it was already patients coming back and saying, I felt better within days. And this has enabled us to change our paradigms of care for UC. At the start of the pandemic, I set up our daily flare clinic where patients would phone into the nurse helpline. The nurses would triage the call in the morning. We would discuss it at our mid-morning IBD huddle. The at-risk patients would be brought to the flare clinic 2 hours later. That same day, they would be seen by consultant, fellow, pharmacist, nurse and dietitian. And we would start therapy when it was needed. And the importance with JAK inhibitors is that you can start that day and the effect can start very quickly. And with an effective multidisciplinary team, you can really start to make a difference. Our nurse helpline takes a lot of phone calls. We have an old school phone system. It works for us. But look at the volume of this. This is in Edinburgh, right, where we have a mature population. But look, we've gone from 2,000 calls a year in 2018 to over 7,000 a year in 2022. And that number has gone up and up and up. So we've gone from 2 specialist nurses to a team of 7 in a period of 5 years. So sticking to ulcerative colitis, this data has not been shown anywhere yet, Rupa. This is hot off the press. Alex Elford, my fellow, has just produced this. This is our first-line therapy for ulcerative colitis, year by year. And so if you look on the left-hand side here, the date here is 2005. So we were using a bit of infliximab as rescue therapy, okay? A bit of infliximab as rescue therapy, but up until 2014, there's basically no maintenance therapy for ulcerative colitis. We then get infliximab, adalimumab, and vedolizumab. And you can see the vedolizumab, you can see the infliximab, you can see here the filgotinib starting to come in. That's first-line use. This is now second-line use over the same time frame. And this Sankey diagram then shows you what's happening to patients over time. It's extraordinary. This is from diagnosis onto the first advanced therapy, and then you can see people going from first to second to third to fourth, some even onto their fifth line of therapy. And we're now trying to work out what therapies are best for what patients. We can look at the persistence of drugs over time. It's vedolizumab and filgotinib, interestingly, in our cohort that seem to have the best persistence, with tofacitinib and adalimumab having the worst. Infliximab actually faring pretty well in our cohort. And then the important surgical piece of data is that this is what's happened to our surgical rates. This isn't raw colectomies. This is all population-based. So this is colectomy rate per 100 UC patients falling year on year, but this dramatic drop in line with our increased use of advanced therapies. This is so important to us because we can go to the payers that are responsible for our drug budget and say, look, we're auditing everything we do. We're looking at response and non-response rates. We're looking at persistence. But we can also show you that hospitalizations are going down. We can also show you that surgeries are going down for Crohn's disease and for ulcerative colitis. So how do we approach ulcerative colitis in 2024? Well, the most important lesson still is that with all these advanced therapies, despite them all, a very significant proportion of UC patients will do just fine, thank you very much, on mesalazine. Give them all top and tail to start, unless they just have proctitis, in which case just from the bottom. If they respond to that, brilliant. We maintain them all on 2 to 2.5 grams per day. We don't drop lower. I know you might be able to do that here. But if they've got more moderate disease, the choice is mind-bogglingly long. I think thiopurine monotherapy remains a good option for ulcerative colitis maintenance therapy. We don't need to use it now because the other options are as cheap. We're typically going vedolizumab or filgotinib or now etrasimod first line, partly due to cost. For moderate to severe, we're using infliximab. We're using a lot of subcut infliximab and then upadacitinib. And we're now about to start a very ambitious rescue study with upadacitinib in acute severe ulcerative colitis. But what really drives our treatment decisions? Cost, yes. Guidelines, yes. Local availability, yes. Experience and familiarity, almost certainly. Limited head-to-head data, we've got CView I've shown you, we've got Vasti that shows that Vedo's better than adalimumab. We've, of course, got Sequence looking at risankizumab versus ustekinumab. We've now got Vivid1 and Galaxy. Doesn't help us every situation. We've got the latest, greatest network meta-analysis. There are a lot of them now. But increasingly good real-world intensity matching, and probably also, not least, the latest marketing hype from the pharma companies. With all of this, I think we are now personalizing medicine for our patients. But this is not, to my disappointment yet, precision medicine. So it leaves us with this big gap. And this big gap we can call the therapeutic ceiling. This therapeutic ceiling where none of our therapies are getting our patients greater than 40% healed. None of our therapies can really break through this ceiling because we're not yet putting all the bits together. And this is early diagnosis. It's molecular stratification. It's improved care. It's improved systems of care. But it's also new classifications and new therapies and new combinations as well. Notice some of these things we can already do and probably are already doing. Early diagnosis, risk stratification, early treatment, improve standards of care. I've seen all 4 of those in abundance here today, so credit to you all. We are very excited about combinations, and as the cost of the new drugs plummets, we can really think about this. And we are doing this already in our clinical practice. We can combine an anti-TNF with a P40 or P19, like's done in Vega, where you've got gazelkamab plus golimumab in UC, and you see improvement in clinical endoscopic and histologic outcomes. But when you look at the biopsies and you do transcriptomic profiles, you don't see 1 + 1 equaling 2. You see 1 + 1 equaling 100 in terms of what you're targeting, And in my clinic, we're already starting to do vedolizumab with pulsed upadacitinib to get people better. We're doing this with risankizumab and upadacitinib. And if you take Vega, which is currently an expensive anti-TNF with an expensive P19, get to the biosimilar world, we can start to take biosimilar adalimumab, which costs 600 British pounds a year, which is what? 60,000 rupee times 100, plus ustekinumab as a biosimilar, which might be the same. So it's quite interesting. If we're putting a lot of our patients on to optimized adalimumab at twice the price, maybe we give them adalimumab plus ustekinumab for the same price as optimized adalimumab, and it's even better. This is within reach, really within reach, and our job now is to work out which patients we should go to. I'm going to spend 5 minutes just changing tack now because I've got some very exciting, cool data to show you. I could spend hours and hours talking about this, but I'm going to spend 5 minutes on these really key learnings from the PREDICT study. We've been trying to work out how we address the question of what we should eat. In fact, I started thinking about the environment 11 years ago when I went to Guangzhou in China, and I went to teach about IBD there, and I saw the environmental shifts happening in front of my eyes. So we set about this ambitious study to recruit 2,500 patients with IBD in clinical remission to a deep dive into bloods, stool for microbiome and calprotectin, dietary surveys, environmental and lifestyle questionnaires with prospective follow-up over 4 years to compare those who flare versus those that do not. We wanted to look at diet, the environment, genetics, and the microbiota and see how they were associated with and predict flaring Crohn's and UC, looking at a number of dietary factors as the analysis. You can see here that our population is predominantly about 40 years of age. It's slightly predominantly female. You've got a slightly high body mass index, already 25. Disease duration is 10 years. Calprotectin at baseline, these were patients in self-reported clinical remission. Their calprotectin when they come in, the median is 50, but 15 to 18% of them have a calprotectin that's greater than 250. The median drops down significantly because of the maths, but there's 1 in 5 with a high calpro, and you've got 45% of our Crohn's population on a biologic. That's about right for us, and about a quarter of the UC patients on a biologic. So these are self-reported clinical remission, and then we're going to follow them prospectively. It's 2,500 patients, half Crohn's, half UC. What do we find? Well, we find that clinical flares, these are symptom-only flares, accrue quite quickly. We track those by patient questionnaires out to 2 years. But hard flares, this is symptoms plus inflammation, CRP or calpro, and a change in therapy. It accrues at about 5% per year out to 4 years. So if your patients are well, they're going to flare at about 5% per year with hard flares. That's quite useful for planning. The calprotectin proves to be incredibly prognostic. If your calprotectin at recruitment was greater than 250, as I showed you, it was almost 1 in 5, your risk of a hard flare, this is just the hard flare data, is quite high. If it was less than 50, really low, it was actually pretty good. This is 50 to 250, and it separates out. So I think we're going to increasingly get a bit more ambitious with our targeting. These are the people who I think you might be able to stop your biologics on. These are the people who you might not have to follow quite so intensively when your clinics are so full moving forwards over time. And I'm just going to show you 3 highlights from the data. One, the key finding from the dietary data, which is that in our ulcerative colitis population, meat intake was associated with the risk of hard flare. Not in Crohn's disease, but in UC. The more meat people ate, and it was red meat, the more likely they were to have a hard flare. This is all controlled for biological sex, for age, for deprivation, for smoking, for disease, and for calprotectin, for inflammation as well. We also looked at a variety of different psychosocial factors, from anxiety and depression to sleep, somatization, exercise, and alcohol. You can see that about 4% of our population had either moderate or severe anxiety. You can see that about 15 to 20% had moderate or severe depression. And you can see the number with sleep disturbance and some of the other parameters there. None of the parameters at baseline here were associated with calprotectin, which was a bit of a surprise to us. But the key thing was to see how baseline depression, anxiety, and exercise affected flare over time. And the table that shows all of it, I'm not going to go into much of this, but there are some interesting things, which is that anxiety seems to highly associate with the risk of symptom flares, but not actually with hard flares, whereas the depression data I'm going to show you is with hard flare in UC. Sleep, symptom flares, not so much hard flares. Somatization, how do I feel stress in my body? Lots of that with soft flares, but not with hard flares. And I'm going to show you with exercise. Interestingly, no impact with alcohol. So this is the anxiety. So look at this. If you had moderate or severe anxiety, moderate, severe anxiety, no anxiety, your risk of having a symptomatic flare is really quite pronouncedly increased. This doesn't then translate to hard flares, but this is important to patients. But what about depression? And this is now hard flares. If you're a patient with ulcerative colitis, irrespective inflammation level, biological status, your deprivation status, your smoking status with ulcerative colitis, and you're depressed, your risk of having a hard flare is increased. It seems to truly suggest that depression is a pro-inflammatory state. It seems to truly suggest that we should be screening for and treating depression, because this is a bidirectional link. And it's not just, I took it out of here, but we see this for exercise. Patients who had less than the minimum recommended exercise per week also had a risk of hard flare with ulcerative colitis. So those are a few really interesting tidbits from there. It brings it down to me about one particular patient, a 43-year-old diagnosed with UC. She has a proctitis. She's one of the 1 in 5 who has a significant progression. She then has a severe flare. Her severe flare requires infliximab rescue. She's desperate to come off all her drugs. She wants to stop the drugs. She's had a stressful period. She thinks stress, anxiety, and her lifestyle are contributed. So she becomes yogi. She becomes very holistic with her diet. She changes her job. She zooms into my meetings on her telemedicine call from her yoga studio, looking, it's just like paradise, and she's there off all medicines in the deepest remission you can see. It's an anecdote, but I could pick dozens now of these anecdotes, and I think these are really important. So let's be practical. What can we practically do today? Well, at every clinical interaction, we can talk to our patients, because our patients have a lot of information to tell us. And I think we should start by asking our patients what's on their agenda to discuss today. Because when you ask this question, they might immediately say, I just want to know my biopsy results. Or they might say, I want to talk about my mood. Or they want to say, my marriage has fallen apart and I want to talk about that. Or it might be that they've got severe urgency and fecal incontinence. Bowel symptoms, yes. Don't forget about urgency, incontinence and pain. A staggering number of our patients wear incontinence pads on a daily basis. Yes, systemic symptoms. I routinely do a brief dietary survey with all of my patients. I don't do a fancy thing, but I do track what they're eating, what they're avoiding, and what their triggers are. And then any problems with their skin, mouth, joints, or eyes, that tracks all the EIMs. Fatigue. How are you sleeping? Why are you sleeping badly? I spend at least a fifth of all of my consultations now coaching people on how to sleep better. So if you want my top tips for sleep, it's on YouTube. Then I ask about their energy levels and their exercise. Is there anything you can't do that you would like to do because of your IBD? And really importantly, how is your mood? And sometimes people will just not want to talk about it. Sometimes they will. And actually, what I've learned is that you don't need to know the answers to all these questions. You don't need to be able to fix them. Patients just want to be able to talk to you about them. And of course, the parameters that we'll test, but it's the clinical interactions that's so important. We'll do routine bloods, but I haven't got time today to show you our calprotectin data on how we are modeling this over time. I'd love to work with your data to do that as well. We are showing that you can model and cluster patients according to their calprotectin profiles and use that information to subcategorize and work out which patients are at risk of flaring, which are not, and how that predicates on things moving forwards. But how do we move this forwards? Well, actually, what I think we need to do is not put a Western toilet into every bathroom in India. You need to put a smart toilet into every bathroom. In Hyderabad, the tech capital of India, you need a precision toilet that's going to measure the microbiome and the metabolome for you and your calprotectin and tell your patients if they're in remission or not. Mark my words, in 10 years, you'll all have one in your bathroom. Well, you'll have one in one of the hospital suites here. That's it from me. I just want to finish with a word on where we should focus our efforts. We have to build a solid evidence base for everything we do, and that's from the mouse experiments to the human epidemiological experiments to the interventional studies to the behavior change studies that we do to the global setting. And I'm deeply passionate about bringing in, wherever we are in the world, data to learn. We have to think about neglected areas. And strictures and other people are doing this. Microbial and dietary strategies will be pivotal. Rational combinations are coming and they will soon be affordable and transformative. We need to not forget about our special populations. Frailty, elderly, pregnancy, children, people with other unmet needs, trying to get to those underserved communities as you are doing. So inspiring to hear today. Delivery of high quality care to all patients. We passionately believe in biomarker discovery to enable precision medicine. I will talk about this over the weekend, but really what we're looking to do now is not just to look at a static time point, but to look dynamically. IBD is highly heterogeneous and highly predictable, but it's also dynamic, and we can use that to our advantage. You can monitor from A to B to C and then have a predictive system that adapts and iterates and then changes its guidance based on what it's learning. That's where the AI will come in, because it will enable us to do this at scale. And then we get to the last point, which is frictionless and passive monitoring that works for patients with smart technology, digital telemonitoring, and AI. And that will also allow us to bring in the wellness aspects, the psychological and holistic aspects to care. Thank you for having me today. I'm so deeply honored to be here and for giving me your time.
terms of prediction, economies of the South Asian are very similar. South Asian and Southeast Asian are very similar to South American economies. In your prediction for 2100 year, where the burden of IBD is greater in Asian and African economies, but yet the South American prediction did not rise in par. Is there any explanation for that, sir? Like,
It's purely just an interpretation of the graph I showed. The graph I showed was the global population, right? And so it's just showing you where the world's population growth is going to be. What you then see is the expansion is in Africa, and it's particularly in young people in Africa. Africa is the one continent where birth rate continues to increase. There is a huge number of children, adolescents, 20, 30-year-old adults in Africa. That population is expanding massively. So when you get to 2100, Africa is the biggest continent by population size. So the share of that by 1% is IBD. South America for sure is seeing the same increase. South America and India are probably on very similar tracks in terms of the epidemiological phasing there. I think if you look in Brazil and you look in India, for example, you see very similar shifts from rural to urban living, from traditional to Western diet. I mean, the Brazilian story is fascinating. Nestle, who probably pretty evil as a company, have not only usurped natural breastfeeding, but they literally couldn't work out how to feed the West more ultra-processed foods than they already were. They'd made them all ready too fat and eating as much as they possibly could. So they built a ship called the Rio Grande, and they sailed it down the Amazon in Brazil to rural communities and set up a mobile supermarket so that people could come and buy ultra-processed foods. And from there, people got addicted to them and spread the word. And then the shops started to appear, as you see here. But it was literally, that's what happened in the last 10, 20 years. And first of all, the kids get addicted to these greening new things, but then within a few years, the whole family is eating them because these foods are made to be addictive. They're literally made and optimized to be addictive. So we have huge issues to tackle here. I mentioned to a few people at lunchtime, I'm really honored to be with Rupa on this Lancet Global Commission to tackle IBD around the world and to try and think about how we can take on, you know, policy at a truly global level to address what's happening there. But yeah, South America and South Asia.
Any other questions? I think they're all mesmerized. So I think, Charlie, thank you for the talk. And as usual, your cartoons and pictures, we did learn a lot. But I think for this part of the world and for our fellows, I think, and Dr. GV is here, we need AI for preclinical IBD. There is a lot of evidence now that there is preclinical IBD, and that is a few years before there is diagnosis. So when we are doing all these master health checkups and wellness package, I think we should be able to predict, and for that population then prevent. And I think prevention is what we will need. I mean, in the long run.
I couldn't agree more. But yeah, the populations, you see what we've learned from the UK Biobank, where you've got 500,000 people in the UK, where we've got genetic and metabolomic and other clinical and imaging data as well as dietary data. It's not perfect for IBD patients. You really want to have these big data sets in younger people. So if you can encourage lots of 20-year-olds to go and get their wellness check here, or even children, and then collect all these biobank data, you know, why not go even more ambitiously and set up, you know, a Hyderabad biobank where literally you go out to the population and we should do this. And you go and get a million people and you genotype them all. You get dietary data. we get a microbiome sample when they're well, then you'll find out what happens over time, then we'll get to prevention. That's what we should do.
Yeah, and I think diet.
You're ambitious here.
And I think
By the another robot.
Charlie went and saw the biobank that we have, and this last sentence is from that. I mean, and I think you took a picture there, right?
Yeah, you'll need some more freezers though, I think.
Yeah. So
wonderful.
Thank you, Charlie, for coming here.
I
and
could speak to you all for hours and hours and hours, as you could probably tell.
Dr. Jeevi to say a few words.
Okay.
Thank you so much. Actually, that's a wonderful lecture. Actually, it's an eye opener for most of us. Actually, and wonderful the way you put up the whole thing. Actually, it is really mesmerizing.
Thank you so much.
Thank you so much once again
I'm so
for being
pleased to be here. Thank you so much.
Small token, please come here,
Oh,
of appreciation from our side.
oh my gosh.
So this is the traditional Indian shawl.
I'm so honored. Thank you so much. Thank you so much. Oh, this is just wonderful. This shall take pride of place in my office. Thank you very much. This is wonderful. Oh, thank you so much. I'm so touched. Thank you very much. Thank you, Rupa. Thank you so much. Brilliant. This is beautiful. Thank you. Great. I'm around, so if people want to ask me informal questions, please do. Maybe I can take the microphone off now. Before you go into the toilet, still got the microphone on. Was that a meeting? Very much.